Hello and welcome to the topic Polydypsia and Polyuria in the Endocrinology module. By the end of this topic, you should be able to define polyuria and polydypsia, explain the pathophysiology of the disease, outline the causes of polyuria and polydypsia, outline the classification of polyuria and polydypsia, describe the clinical manifestations, outline the investigations done, discuss the principles of management, and finally discuss the complications and prognosis of polydypsia and polyuria. Let's get started. Polydypsia is defined as excessive thirst or excess drinking, whereas polyuria is defined as excessive or abnormally large production of urine, which is more than 2.5 to 3 liters in 24 hours. The word polydypsia and polyuria originate from the Greek terms, and polydypsia is called polydipsios in Greek, which means very thirsty, and the term polus means much or many, while the term dipsia and uria give the meaning of thirst and urine respectively. Let us briefly look at the physiology of water regulation in the body. Hypothalamus is the thirst center of the human body which mediates thirst. Osmoreceptors is the sensory receptor that detects changes in osmotic pressure in the body. When osmolarity of the blood changes, either more or less dilute, the diffusion of water into and out of the cells changed. When there is low blood volume or hypovolemia, hypothalamus mediates thirst and the osmoreceptors stimulate ADH secretion from the pituitary gland to regulate plasma osmolarity to normal. Renin-angiotensin system also play an important role in regulating water content in the human body. The macular denser cells in the kidney is an osmoregulatory mechanism that stimulates the juxtaglomerular apparatus to release renin when they detect high osmolarity in the blood vessels. Renin cleaves angiotensin into angiotensin 1, which will then be converted into angiotensin 2 by angiotensin-converting enzymes in the lungs. Angiotensin 2 will act on the hypothalamus to stimulate the sensation of thirst. They can cause vasoconstriction and release of aldosterone from the adrenal cortex to increase water resorption. When hypovolemia or high blood volume happens, negative feedback of ADH is important. Blood volume increases due to increased water intake and it will cause the blood osmolarity to decrease. This will feed back to pituitary gland to reduce the ADH production in order to reduce water reabsorption in the renal collecting ducts. Low levels of ADH increases the urine volume, which will help the blood osmolarity return to normal. This image shows the pathways of the renin-angiotensin-aldosterone system. There are different mechanisms that can cause polydypsia and polyuria depending on the type. Polydypsia causes excess consumption of fluids that lead to polyuria with hyponatremia. Psychogenic polydypsia is due to excessive water intake caused by psychological influence such as schizophrenia or developmentally disabled patients. Non-psychogenic polydypsia may be due to autoimmune chronic hepatitis with severely elevated globulin levels. Drugs such as oxygen therapy, phenothiazines, and anticholinergics may give the sensation of dry mouth or dry airways, will then cause polydypsia. Hypothalamic lesions such as sarcoidosis may impair the production, transport, storage, or release of vasopressin, also known as ADH, subsequently affecting the ability of the body to conserve water. Uncontrolled diabetes is one of the common causes of polyuria due to high glucose level in the urine or glycosuria that leads to osmotic diuresis. The high glucose concentration in the urine causes the water diffusion into the tubules via osmosis, leading to abnormally high urine output. The pathology that causes decreased secretion of aldosterone such as adrenal cortical tumor, primary polydypsia, central diabetes insipidus, and nephrogenic diabetes insipidus may cause polyuria. Drugs such as diuretics, caffeine, and alcohol may increase the urine output. The causes of polydypsia include diabetes, hypokalemia, decreased blood volume due to major hemorrhage, primary polydypsia, primary hyperaldosteronism, and medications such as anticholinergics and antipsychotics, which will cause dry mouth. Zinc deficiency may cause polydypsia too. This is because zinc promotes fluid absorption more efficiently. However, it can help in reduction of diarrhea and induce constipation. Causes of polyuria include primary polydypsia, diuretics, uncontrolled diabetes mellitus, and central as well as nephrogenic diabetes insipidus. Now, let's take a look at the clinical manifestations of polydypsia. Patients with polydypsia, or simply known as increased thirst, generally would have suffered from excessive gastrointestinal losses such as vomiting or diarrhea. They also might manifest symptoms such as lethargy, cramps, confusion, blurred vision, tremors, ataxia, seizures, and coma. And this could be indicating a central nervous system disorder or a consequence of excessive fluid loss from the body. And in worst case scenario, this can even lead to death. As for polyuria, it's pretty straightforward. Patients will be passing a lot of urine as many times during the day as well as at night. The signs typically we can see would be change in body habitus or BMI. Patients would probably have undernutrition or cachexia. They also might exhibit signs of eating disorders, obesity. They could have signs of dry eyes or dry mouth, such as seen in Sjogren's syndrome, hyperpigmented or hypopigmented lesions, ulcers and subcutaneous nodules seen in sarcoidosis, any focal neurological deficits if there are any neurological insults, thought disorders in schizophrenia, and also edema. As for the signs, one may manifest signs of night sweats, cough, weight loss, extensive smoking history. In order to rule out differential diagnosis, several investigations are needed. Serum and urine electrolytes, which include sodium, potassium, and calcium, must be interpreted. Serum and urine osmolality as well as plasma antidiuretic hormone levels are important to differentiate types of diabetes insipidus. Hypernatremia indicate excess free water loss due to central or nephrogenic diabetes insipidus. Hyponatremia may be due to excess free water intake secondary to polydipsia. Low urine osmolality occurs in untreated diabetes insipidus. Water deprivation tests and exogenous ADH administration may help in differentiating types of diabetes insipidus. Results after the test show low ADH level in central diabetes insipidus, whereas high ADH level in nephrogenic diabetes insipidus. Now let's discuss about the management of polydipsia and polyuria. The management is based on the underlying cause of the symptoms. Severe hyponatremia among clinically unstable patients require hypertonic saline infusion in ICU setting with frequent monitoring of sodium levels. Patients with primary polydipsia may need water restriction and behavioral therapy. Desmopressin and oral or IV fluid to replace urine losses should be offered to central diabetes insipidus patients. Psychogenic polydipsia can be managed by treating the acute hyponatremia, behavioral therapy, prescribing atypical antipsychotics such as clozapine, olanzapine, and risperidone. Demiglocycline, which is a type of tetracycline antibiotics, can reduce urine concentration to control polyuria. Patients with uncontrolled diabetes mellitus require proper, effective, and long-term management targeted to control blood sugar either by oral antidiabetics or injectable insulin. Antidotes such as physiostigmine, salicylate should be given to patients who have anticholinergic poisoning. Zinc supplementation can be given to patients with zinc deficiency, and 2 to 3 times for mild deficiency and 4 to 5 times for moderate to severe deficiency. Now, these are the complications of polydipsia and polyuria. As for acute hyponatremia, one may be having nausea, vomiting, blurred vision, tremors, dizziness, ataxia, confusion, lethargy, and seizures. So they are pretty vague, however, pretty much focused around the central nervous system, and other complications such as bladder dilatation, enuresis, incontinence, hydronephrosis, renal failure, or congestive heart failure. So in summary, polydipsia is defined as excessive thirst or excessive drinking, whereas polyuria is defined as excessive or abnormally large production of urine. Disturbances in regulatory mechanism of water homeostasis is the main pathophysiology in polydipsia and polyuria. Polydipsia can be caused by diabetes, hypokalemia, and decreased blood volume, while causes of polyuria include diuretics, uncontrolled DM, primary polydipsia, central and nephrogenic diabetes insipidus. Investigations of polyuria and polydipsia include serum and urine chemistries such as electrolytes and calcium, serum osmolality, water deprivation test, and exogenous ADH administration. Management of polydipsia and polyuria is based on the underlying cause, severe hyponatremia requiring hospitalization and immediate intervention. We have come to the end of this topic. Thank you.